Thank you, Perry. Thank you, Gianfranco. Thank you, Franco and Jacopo. This is my agenda, but probably at the same time it is my final slide. So if you prefer have a siesta, you can absolutely close your eyes and I will wake you up when these slides will come again in the next 20 minutes. 20 minutes. As in general, probably there are 3 to 4 ways to improve diagnosis and prognosis in the field of restrictive cardiomyopathy. The first way, the first tool, is, I think, improving accuracy and consistency of current definition and classification. As you know, as Perry told, restrictive cardiomyopathy is the most challenging, the most difficult, the most problematic topic in the field of cardiomyopathy. And the problem is that the definition of restrictive cardiomyopathy is a physiology-based definition and not a morphology-based definition. As you know, morphology is much more reassuring than pathophysiology. How the previous definition and the current definition define restrictive cardiomyopathy. In 1994, restrictive cardiomyopathy was defined as an entity characterized by restrictive filling and reduced diastolic volume of either or both ventricles with normal or near normal systolic function and wall thickness. The most recent American classification skipped the problem and focused only on the topic of primary restrictive cardiomyopathy, and here you can see the definition. Once again, normal or decreased volume, normal wall thickness, and restrictive physiology. Some years ago, we used this way to define the entity. And we wrote that restrictive cardiomyopathies are defined as restrictive ventricular physiology in the presence of normal or reduced diastolic volumes, normal or reduced systolic volumes, and normal ventricular wall thickness. In turn, restrictive left ventricular physiology is characterized by a pattern of ventricular filling in which increased stiffness of the myocardium causes ventricular pressure to rise precipitously with only a small increase in volume. It's a nice description, but it's quite difficult to translate this description in the clinical practice. This definition and this classification is perfect if our entity, if our cardiomyopathy is the so-called idiopathic restrictive cardiomyopathy. It could also be a troponin E-related cardiomyopathy. Normal functioning from a systolic point of view ventricles, but extremely enlarged heart, this is an explanted heart, deep plateau in the hemodynamic curves, and a large amount of intramyocardial fibrosis. Indeed, as we wrote, the list of diseases causing restrictive cardiomyopathy is a huge list, including familial and non-familial entities. Probably is more convenient to subclassify the causes according the plausible myocardial substrate, interstitial fibrosis, infiltration, storage, or endomyocardial disease. However you look at the problem, the concept is that you have a huge spectrum of disease from a morphological point of view, starting from the absolute sobriety, I would say paucity of morphological findings of the idiopathic restrictive cardiomyopathy to this impressive richness of morphological abnormalities of endomyocardial fibrosis, right type, endomyocardial fibrosis of the left ventricle, and so on. Now, at least 2 questions. How frequent is restrictive physiology in restrictive cardiomyopathies? And how frequently are ventricular thickness and systolic function really normal? If you consider the most popular, the most typical of restrictive cardiomyopathy, cardiac amyloidosis, and you want to know, you want to measure how frequent is the presence of a restrictive physiology, these are the data, as you know. You have to consider in around 100 patient study by means of hemodynamics and echo. Deep plateau, restrictive filling pattern on echo, both capillary and right atrial pressure increased, only right atrial pressure, only capillary pressure, either or at least one marker. So the range is from 3% of the cases with a clear deep plateau in the right ventricle, to 41% with the restrictive physiology in echo, to 77% with at least one abnormal diastolic marker. So we are very far from the perfect idyllic situation that the classification and definition shows. Again, if you consider the pathophysiological profile of patients with heart failure and amyloid disease, as Simone Longhi, which is the following speaker, will debate in detail, here you can see that no more than 60% of the patients have heart failure due to diastolic dysfunction. Systolic dysfunction is involved in a large proportion of patients with amyloidosis. And if we want to restrict the definition only to patients with normal thickness and normal systolic function, this is the result, a very limited list of conditions which can be defined as restrictive cardiomyopathy. Now the question was also debated on the introductive lecture on Wednesday. Do we have to change the classification? Are we happy about this classification? As you know, as Shakespeare wrote, what's in a name? That which we call a rose by any other name would smell as sweet. So in other terms, the names are not so important. The names are just synonymous of concept. As we know, not only William Shakespeare, but another English author, Eliot, has the same cultural position regarding this realistic approach to classification. And I completely agree with Perry. However, we have also to consider the so-called nominalistic position, typical of the Middle Age philosophy in Italy and in France. So it's the position of the name of the rose. Stat rosa pristina nomine, nomina nuda tenemus. So in other terms, the concept of rose, the universal concepts, exist only in the name, and we have only bare names. So it is quite dangerous becoming convinced that the general concept exists, since the name carries on this concept. For example, if you are really convinced that an entity named heart failure with preserved ejection fraction exists, and this pathophysiological label is stronger than the differences between individual patients, we can produce some damage. For example, we can include in trial patients just because we believe that they are affected by this entity, and this is our result. No single trial in the last 20 years produced anything right, including patients because of the name diastolic dysfunction. So, I don't know, we could probably think it over. Possibly, at least, infiltrative disease could deserve a particular nosographic individuality, I would say. I don't know. From a practical point of view, as you know, the clinician has two tasks, two problems. Determining the presence of a cardiomyopathy, and in particular a restrictive cardiomyopathy facing a single patient, and at the same time to make the etiologic diagnosis. In the case, for example, of endomyocardial fibrosis, it's very easy to be sure that a cardiomyopathy is present, and it's absolutely easy to make the differential diagnosis. The situation is different if we consider, for example, this entity, idiopathic restrictive cardiomyopathy. Here, it's relatively difficult to be sure that a restrictive cardiomyopathy is present, and also the etiologic diagnosis can be problematic and challenging. Just an example, as you know, the concept of pulmonary hypertension is trendy in the current era. Many industries are producing drugs for the treatment of pulmonary hypertension. Many seminars dedicated to pulmonary hypertension exist. And so many patients are labeled just as having pulmonary hypertension without analyzing the underlying entity, the underlying possibility. Indeed, in many cases, in our experience, with the final diagnosis of restrictive cardiomyopathy, the first diagnosis, the wrong route towards the right diagnosis, was represented by a label of pulmonary hypertension. Of course, you can diagnose the presence of a restrictive cardiomyopathy. You have at least 34 Doppler and echo signs, which I'm not going to discuss. Just a general concept. It's more easy to understand this difficult sign if you use a metaphoric definition of restrictive cardiomyopathy and also of constrictive pericarditis, which is the classic differential diagnosis. Restrictive cardiomyopathy is a sort of fight of atria against ventricle in a context of diseased myocardium. Whereas constrictive pericarditis is the fight of the right ventricle against the left ventricle during inspiration for the dominance of the pericardial space in a context of normal myocardium. If you can fix this concept in your mind, it's more easy to interpret the different M-mode or Doppler sign. Of course, a differential diagnosis is necessary, and at least 3 entities underlie this situation: sarcomeric restrictive cardiomyopathy, desmin-related, and idiopathic restrictive cardiomyopathy. I agree with English colleagues that probably idiopathic restrictive cardiomyopathy is destined to die. Probably it will not exist longer in the next years. In many cases, the patients have indeed mutation of the sarcomeric gene. There is an important red flag that electrocardiogram can give you, and is the presence of AV block associated with the restrictive phenotype, and this red flags indicates a high probability of desminopathy. And another red flags in the family, but the family is the patient, as Philippe told us, is the presence of a mixed phenotype. When you are facing a mixed phenotype in the pedigree, probably the underlying condition is a sarcomeric-related restrictive cardiomyopathy. In the final minutes, we are going to discuss a very important problem, in my opinion, how to improve diagnosis and prognosis in relationship to the infiltrative disease, and in particular with cardiac amyloidosis. Other tools: increasing awareness and diagnostic suspicion, and optimizing clinical use and interpretation of diagnostic tests. Culture, I mean knowledge, is absolutely important in detection and in diagnosis, not only ability in observation, not only ability to spot inconsistencies. And there is, as for TTR, Transthyretin-related cardiomyopathy, a problem of knowledge. You know that the amyloidosis is a strange disease where different proteins can fibrillate and produce an infiltration within the tissue. The most popular, the most known, is the AL1, but there are also two entities that are largely underdiagnosed: the mutated Transthyretin-related amyloidosis and the wild type or senile. These are absolutely underdiagnosed and poorly known. Mutated Transthyretin is a familial entity with a worldwide diffusion. It's difficult to study. So recently, we, with Pfizer, decided to set up a worldwide registry, which is now collecting around 1,500 patients with this disease. You know the geographic distribution of these patients. And we found that 53 mutations are responsible for the disease. And there is a useful albeit funny, but the gene is very small, as you know, genotype-phenotype correlation in this disease. At your left, you can see specific neurologic mutation. If a patient carries V30MET, the probability of having a pure neurological disease is absolutely high. But if the patient has one of these mutations or the wild-type condition, the probability of having a pure or dominant cardiac phenotype is absolutely high. In this registry, for example, around 25% of the patients had a mainly cardiac phenotype from a symptomatologic point of view. In a recent study, European study, Italian study, this proportion was around 17% with exclusively cardiac phenotype. And the most important thing is that there is a general profile of Transthyretin-related cardiomyopathy with exclusive cardiac phenotype. Male gender, average age 62 years, apparently no family history, heart failure, concentric, which means symmetric left ventricular hypertrophy, absent or mild dilatation, and so on. This is important in the differential diagnosis with hypertrophic cardiomyopathy. Very briefly, is electrocardiogram important in order to make the differential diagnosis? Absolutely yes. We have to look for the infiltrative phenotype hidden within the hypertrophic one. We know that low QRS voltage are an important tool for differential diagnosis, but unfortunately, low QRS voltage are frequent only in the AL amyloid, and they are definitely low. The frequency is definitely low in transthyretin-related disease. So we have to shift, to move from the concept of low QRS voltage to another concept, the concept of the relationship between QRS voltage and LV mass. If we put some hundreds of patients in this Cartesian plane, mass, echocardiographic mass on horizontal axis and QRS score in vertical axis, you see that hypertensive heart disease are here, hypertrophic cardiomyopathy patients are here, whereas amyloid patients are here with this horizontal sloping. So if you want to make a differential diagnosis, or if you want to foster a diagnostic suspicion, you have probably to perform this calculation. Total QRS score divided by LV mass index. In a large study involving around 500 patients, we found that this cutoff value is particularly useful in the clinical practice. So no longer low QRS voltage, but total QRS score divided by LV mass in our experience. I'm not going to speak about echo. It's too easy, it's too popular, and time goes by. Just a concept related to MRI. Once upon a time, at the beginning of the era of MRI evaluation of amyloidosis, we supposed that this pattern was specific and sensitive, subendocardial accumulation of gadolinium. Now we know that this is not true. Recently we had the opportunity to cut 12 hearts, 12 explanted hearts, and please note the black is the computer transformation, is the amyloid, and the pink is the normal myocardium, that the pattern of infiltration can be widespread, subendocardial, or scar-like, as in this case. And the most recent papers dedicated to magnetic resonance shows that the same variability, the same spectrum can be detected also on MRI. But probably the most typical sign of amyloid infiltration is this, the avidity of the myocardium for gadolinium. At a short T1, large part of the myocardium goes to the null point earlier than the blood. So myocardium, as you can see, gets black earlier than the blood. This is the most important, the single most important sign. Recently, we are moving. These are data from the London group by James Moon and colleagues, this concept of equilibrium contrast of gadolinium in magnetic resonance, which allows a quantitative evaluation. These are the first studies dedicated to this concept of quantitation of the interstitial expansion by means of this equilibrium technique. So this is the future. But there is, and I'm finishing, another important technique, which is scintigraphy. Bone scintigraphy in particular. Please note the slides. A normal subject, in C, a mutated TTR patients, in D, a senile patients, and in B, an AL amyloidosis. In the normal, all the technetium goes into the bones. In patients with TTR-related amyloidosis, here, all the technetium goes within the myocardium. So high avidity of technetium by the myocardium in case of TTR-related amyloidosis. In AL, this is not true. So you can use this test to help you in the differential diagnosis between AL and TTR-related amyloidosis. Is a real problem in the clinical practice. Or you can use this tool to quantitate the amount of amyloid within the myocardium to stratify the prognosis of the patients, or, and this is very important, to identify the initial cases, so to perform the early diagnosis. In this case, for example, normal ECG, normal echo, but positive scintigraphy. And so we were able to identify up to 7 cases with normal echo, but with positive histology for myocardium in case of TTR. And this is particularly important, in my opinion, you can use scintigraphy to identify patients with senile systemic amyloidosis or with mutated TTR with exclusively cardiac phenotype and perform a differential diagnosis in relation to hypertrophic cardiomyopathy. For example, a patient with symmetric important hypertrophy, normal ventricular function, left bundle branch block, could be hypertrophic cardiomyopathy, but the scintigraphy is positive. Whereas the same in analogous patients with hypertrophic cardiomyopathy doesn't uptake technetium. We have studied this problem, and the conclusion is that non-amyloidotic cardiomyopathy do not uptake technetium, whereas only TTR-related cardiomyopathy uptakes the technetium. So, in our experience, it really helps in the daily activity. As I promised, this is the final slides, so at least 3 important points, but the final aim is choosing the right therapy. As for TTR-related amyloidosis, now we begin to have useful and important drugs. One of these drugs is tafamidis. Tafamidis is a drug able to stabilize the amyloidogenic protein precursor, avoiding the precipitation in fibrillar structure and the tissue precipitation. We are now performing trials dedicated to heart disease. The first 3 trials dedicated to the neurological part of this disease are finished, are ended, and the drug is now available in Europe for the treatment of patients with the neurologic phenotype of the disease. So, thank you so much. I've finished.
Maybe just while you're thinking of your questions, first of all, the philosophy, Claudio. So, the fact that we've been debating restrictive cardiomyopathy for 50 years suggests that it's not the entity, but it's our measurements, it's our concepts that are wrong. And you inferred that in one of your early slides. So isn't this a problem? If we were to say we could determine systolic function by measuring end diastolic volume or dimension, that's as crazy as saying that we can detect restrictive physiology by measuring a filling pressure. It's a surrogate, but it doesn't actually tell you about diastolic function. It tells you about the extreme consequences of diastolic dysfunction. This should be a dynamic assessment, surely.
You're absolutely right, Perry. I believe that we need very simple tools in the clinical practice. For example, if we measure with strain or strain rate the longitudinal function, or in general the deformation index of the myocardium, I think that no one case of amyloid can be defined normal. We tried to perform this evaluation in 10 cases with idiopathic restrictive cardiomyopathy, and we found that in 7 out of these cases, these indexes are abnormal. So, a very simple approach: circumferential function, volumes on the ventricle. You are absolutely right. You know, the smell of the rose is the same independently upon the name, I'm pretty sure. But if you strongly believe that, for example, amyloid disease is a restrictive cardiomyopathy, and you need to demonstrate restrictive physiology to make the diagnosis, you can be wrong.
Well, are we though? Because the definition, which wasn't just English, it was Anglo-Italian of restrictive cardiomyopathy, was a dynamic definition. Yeah. It's the change in pressure with volume, and that's what we don't assess clinically. We measure the filling pressure, which is only raised when you have an extreme form of restrictive cardiomyopathy. And you show that very nicely in your data on amyloidosis. The filling pressure is often normal, but the diastolic behavior is not. And that's what we don't assess in everyday practice.
Yeah. This is the problem, the discrepancy between the clinical practice and the concept, the pathophysiological universal concept.
Yeah.
Claudio, as usual, I mean, wonderful presentation. Now, 2 things. One, you launched tafamidis, but you left us alone. I mean, you just said that it's available in Europe. What does it mean? I mean, can you tell us a little bit more about it first? Second point, you skipped the echocardiography. Why? Because it's too easy, but is it useful at the same time, beyond being easy?
He skipped it because I told him he only had 20 minutes.
Yeah, this is the answer. No, the question about the tafamidis is very important. The European agency approved the use of tafamidis in the treatment of patients with Transthyretin-related amyloid disease and neurologic impairment, stage 1 neurologic impairment. FDA has not yet approved. They requested one more study, and the study is now currently performed in both Europe and USA. At the beginning, in this month, we are starting a trial dedicated to the treatment of heart disease, enrolling both patients with the mutant form of the disease and with the wild type of the disease. Please consider that when, for example, just our experience, it's easy to speak about our own errors. When we decided to study in detail TTR amyloidosis and to study senile amyloidosis, we realized that at least 3 to 5 cases previously labeled as hypertrophic cardiomyopathy, aging 65, 72, were indeed cases of senile systemic amyloidosis, apparently normal function, no low QRS voltage. We had the opportunity of seeing also USA patients initially labeled with hypertrophic cardiomyopathy, but they were indeed affected by senile systemic amyloidosis. So consider that in each center treating patients with hypertrophic cardiomyopathy, a small but not so small proportion of patients has indeed Transthyretin-related amyloidosis. That's one of the reasons, since we believe that having a drug, of course, can modify the culture, the approach.